Well, good evening and welcome to the University of Minnesota MHA Leadership Interview Series. I'm Dan Zismer, Program Director. Special welcome tonight to students, faculty, and guests here. Joining us tonight is Dr. Barry Silbaugh. Barry serves as the Chief Executive Officer of the American College of Physician Executives. Barry has a distinguished career in several areas. First, he was a practicing internist for a number of years, succeeded well there. Has been a physician executive for a large Catholic health system. Now leads a growing college of physician executives and leaders, and I think the membership numbers in excess of 9,000 now. And also Barry was listed as within the top 100 most powerful folks in U.S. healthcare. Number one on the list was President Obama. So Barry, welcome, and thank you for joining us here tonight. It's a pleasure.
Thank you, Dan.
Tonight's topic is physicians as leaders and executives. Obviously, Barry leads the College of Physician Executives, but also has been a physician leader himself in a number of settings. I'm especially happy to have you here for a couple of perspectives. One, because you know what you're doing, and I appreciate that, and thanks for coming. But also, this curriculum was designed specifically to mix physicians with non-physicians to create an executive MHA degree. And our philosophy of that, we believe that health systems are going to be led by teams. We believe that physicians will be parts of those teams. Sometimes physicians will be leaders, sometimes they'll be executives, sometimes they'll be followers. But we really believe in a collaborative approach, and that's why we designed this program to include physicians and other professionals, clinicians and non-clinicians. So that was by design, and we'll be interested in your perspectives of that as we move forward. I gave you a brief introduction, and again, thanks for coming. Anything else they need to know about you and your connections here?
Sure. I mentioned that this is one of my favorite cities in the world, and it truly is. I did my internship here right after medical school. I started off to be a surgeon, and I worked at the old Hennepin County Medical Center. During that year in the Twin Cities, I decided I was not going to go into surgery after all. But I thoroughly enjoyed the city, the design, the influence of the different cultures. The Guthrie Theater was just down the street from where my wife and I lived at near Lake of the Isles, and I always enjoy coming back here, even in the middle of January. So now that I'm working out of Tampa, Florida, which is where our headquarters is, my staff often wonders, how can you possibly enjoy that kind of weather? And I tell them that there are 3 days of summer right after July 4th, and that works pretty well for a lot of us. So thanks for having me. It's great to be here.
It's a pleasure, and I appreciate your taking your time. I know you have a busy schedule. Before I launch into questions about this whole notion of physician as leaders, I know you're beginning to take the college in a perhaps a different direction, but I'd like you to talk about your philosophy of physicians as leaders and how that fits with the college's philosophy, if they're the same or different, and where do you think you're going with that?
Sure. The college was organized about 34 years ago as the American Association of Medical Directors. At that time, physicians were just starting to get into the healthcare industry in management roles, but most physicians at that time had no management background or training. Over the years, it became obvious that physicians to do well in these situations needed to have that kind of training. So the name changed about 10 years ago to the American College of Physician Executives, which is what ACPE stands for. Having said that, what I'm finding in my new role at the college over the years that many physicians don't particularly resonate with the term executive. Physicians that I've talked to that most people would say are legitimate executives. They own their practices, they lead large medical groups, do not think of themselves oftentimes as executives. They say we're physicians first, we're leaders, we might be entrepreneurs or owners, but they have a reluctance to talk about that word executive. So what our board has just come up with, the first ever mission vision statement for the college in the past year, is we're the world's premier organization for lifelong growth and support of physician leaders. And we do this because we want to inspire physicians to think of themselves as leaders. or team members, and we do this because we want to improve health in the nation. Our board and I would like to have the college be more relevant than it has been in the past in terms of changing the healthcare system, improving the healthcare system, whether it's improving one clinical process at the bedside or whether it's leading a healthcare system. It doesn't really make any difference. Those are all leadership opportunities for physicians. The other thing that we've recognized at ACPE is that the world has changed since ACPE was organized, and even over the past 20 years or so, that the autonomy of physicians and the insular nature of our profession has to change to more, as you mentioned earlier, teamwork, working with multidisciplinary teams and abandoning that autonomy that we've all been trained with as clinicians in favor of teamwork and group process. So to that end, our board has just approved new membership categories within the college. Not only is it MDs and DOs, we've also added podiatrists and dentists that have interest in management and leadership. And we've also created new classes of membership for clinical affiliates and healthcare leaders, not necessarily with a clinical background, because we want to know how to work effectively in that multidisciplinary team setting. It's often been, if you get a lot of doctors sitting together talking about hospital administrators, leaders, executives, you'll often hear the term, "they don't get it." And what we want to do is say, well, what is it that they're not getting? And how do we define what we think as physicians is important? Is it really different from what non-physicians think and how non-physicians lead? So we think that by focusing on teamwork and how we as physicians can be, and I'm not just leaders, but I think there's an intermediate step that we've maybe ignored, and that is before we can be a leader, we really need to know how to be a good team member, member of a team, a follower perhaps. And then after you've been in those roles, then it may be a natural progression to say, okay, now I can lead this team, or someone may ask a physician to lead. And the skills and the techniques that physicians acquire in medical school oftentimes are not the skills and behavioral competencies that we need in a team setting.
It's about 9,000 members or more than that, and is there growth?
Yes, as of this morning, it's about 9,400 members, and we're seeing very steady growth coming out of this recession, if the recession is indeed over. We're seeing a lot of younger faces as well than we have in the past. We think that has in part to do with career options that physicians are looking for, uncertainty about change in healthcare and the roles that physicians will play, even things like the shortage of primary care. It may be that physicians will not be doing one-on-one patient care in much larger numbers than they have in the past, but they may be leading a team of other healthcare professionals. So yes, we're seeing steady growth, and that's very gratifying.
And if I heard you right, you're adding non-physician members to the college?
That's correct. This hasn't been announced in the media yet. I'll be talking to my board in a couple of weeks. We want to make sure that we know how to, as a staff, how to make sure that this happens in a way that is consistent with the board's decision. So,
now we've talked in class, and I'm sure you're recognizing the demand or apparent demand for more physicians as leaders in community health systems. What do you think the drivers are?
Well, that is a really, really good question, and I think what's driving this is something that's happening across the country, a much more public focus on quality, outcomes, and patient safety. And if I can borrow some concepts from the systems science of safety and engineering from many high-risk, high-consequence industries, I think the reason this is happening is that highly complex systems, especially ones that do risky work, have often been described in the safety literature as having what's called a blunt end and a sharp end. Think of an inverted triangle with equal sides. At the blunt end is where senior leaders do their work. where boards do their work, where strategy is formulated, where missions and visions are formulated for an organization, regardless of size. The sharp end, on the other hand, is in healthcare, the patient care interface, where the rubber hits the road, where all of those strategies, missions, and visions interact with the patient. And what needs to be done to have high quality outcomes and high performance in the realm of patient safety is you've got to be able to connect what's happening at the blunt end in strategy, et cetera, with specific human behaviors at the sharp end. And physicians are typically working at the sharp end, but I think people have an understanding that if physicians got the right training, had the right behavioral competencies, could be very, very helpful in terms of formulating those strategies and then being able to implement them all the way down the line. For example, let me talk about a very specific example. If my goal at the blunt end as a leader of an organization is to have the safest healthcare system in the region or maybe in the country, that would be an overarching goal. Maybe then you develop policies and procedures that would say, how are we going to do that? Well, we want to have a very low hospital infection rate and hand washing, things like that. You need to be able to go much farther than that, all the way down to very specific human behaviors like spending 15 seconds or singing happy birthday when you're washing your hands or something like that, so that individual human beings know exactly what they have to do to make sure that they're delivering highly reliable health care. And physicians, I've noticed in my career, seem very comfortable at the sharp end, but increasingly if they see something that they don't like, they feel very comfortable knocking on the door of the hospital CEO and telling them about what they don't like. And there's very few professionals within the healthcare hierarchy that feel equally comfortable, I think, interacting with people at both the blunt end and the sharp end. So I think that's what's driving this, that every community hospital wants to serve the community as well as possible, and that means having a safe place where, first of all, people don't want to be harmed. Second, they want to be healed from whatever is wrong with them. And third, they want people to be nice to them. And physicians tend to know something about each of those three different categories.
You know, when we think about physicians being part of the management teams, I've heard a number of folks, whether they be experts or practitioners or consultants, say, well, you know, these physicians, they just think differently, and you got to be aware of that. They just think differently. Do they?
I don't think so. I think there's I think you can have non-physicians that also think differently and behave like some of the best physician leaders. But I don't think that you can make a blanket statement that physicians think differently. Probably the closest thing that comes to that is being aware of evidence-based medicine, being aware of the impact of organizational decisions at the blunt end on an individual patient sitting in a hospital bed or being in an operating room. I think that part is true. I think there are some differences in management styles, perhaps, one of which is the oftentimes quick decisions that physicians will make. They don't always tend to be paralyzed by analysis like many of us internists tend to get accused of. So I think there are some subtle differences, but you know, the best leaders that I've seen not only maybe think a little differently, but they act differently as well. I can give you a specific example of something that impressed me at a hospital in the Midwest that I went to a couple of years ago when I was working with a consulting firm on patient safety. The hospital was led by a physician CEO who was a family physician, been in the community for many years, and I was in the ICU. I couldn't quite figure out why they had had no ventilator-acquired pneumonias for 50, that's 50 months. That was the best I had ever heard of. And I thought, they must have the Holy Grail here. They must have figured out something that nobody else in the country had figured out. I went up to the ICU, I talked to the nursing staff, and I'd also been interviewing other people about this physician's leadership style. One of the things I noticed, first of all, they said each one of us is responsible for each patient. We don't just have 2 patients that we're responsible for here in the ICU. Each one of us is responsible for every individual patient. I said, that's great. They said, we don't have a charge nurse here. We don't need one, because the charge nurse would tell us just that. And then I noticed that there was a picture of the CEO, the physician CEO, behind each bed in the ICU. And I said, what's that all about? They said, well, we decided
Narcissism, maybe?
No, no. There's other narcissistic tendencies, but not this guy. They said one of the 5 components of the ventilator bundle is head of bed elevation at 30 degrees so that you don't get gastric contents in the lungs. And they said, if that patient's bed is flat and there's no good reason for it, the first thing we see when our eyes scan that room is the CEO's picture. And I thought, it probably takes a certain kind of personality to say, yes, I think that's a good thing to put my picture up there so that when something's not being done right. So there may be something there about how, the other thing they told me was he runs the hospital like he did his clinical practice. Everybody in the hospital is focused on each patient in the hospital. Maybe less focused on the bottom line because he knew that what made the bottom line strong was doing things clinically properly. So that's probably the closest thing I can come to thinking differently.
Yeah, a related question, and go a little bit off script here if you don't mind. We were having discussions today, in fact, that the higher up you go in an organization, the longer you have to wait for the results of the decisions you make. And we've talked about, and I've talked about with the class, and these are very experienced students, and I said, don't fall in love with making decisions, because your world will get very small very quickly. And you mentioned and referenced that physicians are used to making decisions quickly with in relatively compressed time frames, and the results are known relatively quickly. As a physician executive and leader of the organization, do you talk to physicians about that? That you're accustomed to making decisions that have a consequence in the next minute and the next 5 minutes, but as you become a leader, you have to look more out on a horizon. Is that part of the curriculum, your curriculum, so to speak?
Absolutely. That's part of what we talk about. People say, well, how's it going to be different in management? Well, first of all, when I was in clinical practice, I would come home exhausted every day, having made at least 50, maybe 75 or 100 decisions. Every patient, maybe 1, 2, or 3 decisions. And because of the autonomy that we've been granted as physicians, you can do that. And the staff, whether it's the hospital or the medical practice, know that, yep, that's what we need to do. So you come home and you say, wow, I made a lot of decisions today. You go into management, you may not make a decision for a month that has that kind of impact. But when you do make that one decision, it can be a real whopper. So what I tell physicians is, if you're looking for validation every day in terms of your autonomy and how many decisions you make, you may not necessarily get that in management. And you have to understand the differences between the cultures of medicine and the cultures of management. It's much more working in a group setting, getting input from people. Bill Kissick, MD, PhD from, I think he's emeritus now at Wharton, several years ago described the differences in the 2 cultures. And getting to the point that you mentioned, he talked about medicine being reactive, because you have to make decisions as a physician. If somebody has a fever, low urine output, you don't have time to get a lot of data before you make decisions. And you have to be reactive, and that's a good thing. On the other hand, if you're in management, you have to be anticipatory. Think ahead about what impact is this decision going to have, and that's a good thing. But the 2 cultures are really different, and for physicians going into leadership and management roles, it's essential to recognize that. And as we mentioned earlier, it's one of the reasons that I took up stonemasonry as a hobby, because I thought it felt a lot like management. It takes a long time to build a solid foundation, and You have to figure out the mosaic of working with people, how to see something that isn't there yet, and how to slowly and deliberately build that. That's taught. And the other thing I mentioned, I guess, in our previous conversation was how goal-directed I used to be as a physician. It drove my wife nuts and drove me nuts, frankly. Now what I do is I tend to say, am I enjoying every single moment that I'm working? Am I enjoying this moment? Absolutely. Will I enjoy the moment tomorrow? I probably will, but I won't know until I'm in that moment. And it's helped me tremendously. It doesn't mean you can't have missions and visions and goals for the future, but to focus on that but not enjoy getting there, the hard work. Work is messy. Decisions are messy. And that's something that I think a lot of physicians don't realize until they make that leap into management.
You know, you talked about the philosophy of the college moving perhaps more to being more collaborative. Now, you could see physicians working in teams as long as they're head of the team. Do they have to be the head of the team?
No. In fact, I would say in most cases, they're not the head of the team. They're a member of the team and need to learn how to behave and act that way. What makes a good team member? How do you fit into group process? Understanding the importance of silence in a group discussion. One aspect I think that's really important that I don't think most physicians appreciate until you get to this moment in your career when you're asked as a member of that team to support something that perhaps you personally would not have done if you were leading that team. Can you do that without trying to sabotage the other people on the team? If it doesn't cross an ethical boundary for you personally, my belief is that you can do that and you should do that, and that's probably the mark of the consummate professional.
Now, I've had the pleasure of attending a number of the college's meetings and have appreciated that, and I noticed that a growing proportion, and perhaps most, are younger than I am. So talk about the younger physician moving into leadership positions, management positions. We were chatting today, the students were talking about how there was a time, and perhaps the time is still for some organizations, where the physician moving into an executive or management position was a later stage decision in a career. Perhaps they were just burned out practicing medicine, so it was time to try something else. Doesn't seem to be the case now, and it certainly isn't the case in our class. But what are you seeing in the college?
Yeah, that's absolutely correct. It used to be that it was a way to slide into retirement. Didn't need any management training or experience. But the younger group, it's interesting, if you look at the medical schools in this country, at least 50% of them now have a combined MD, MBA dual degree program. It's a small percentage of each class that chooses to do that, but there's a growing number of those physicians, and what we hear from them is that many of them have no intention of practicing clinical medicine when they finish their medical school. They don't plan to do residency, some of them. They plan to go into the industry in various roles in pharma, maybe on Wall Street, etc. There's others that believe that they can get those 2 degrees and go into a health system and be a leader. The older physicians will say, well, you really need to have some clinical background before you do that, or you won't have credibility with your colleagues. I was on a conference call with some of our physicians, and one young woman physician said, I don't believe that. We're a younger generation. We don't see things the same way as the older generation, and you certainly know the differences in lifestyle, what's important to younger physicians versus older ones. And they said, no, we would listen to someone like that. What we are seeing is a lot of physicians that have been in clinical practice for, it used to be, years ago, I could pretty much predict when I'd get a call from a physician that was thinking about a career change. They were usually about 13 to 15 years out from the end of their residency or fellowship training, almost like clockwork. That's not true anymore. These may be physicians that have practiced for 3 to 5 years. I talked to a physician a couple of years ago who had been in practice for a year as a medical oncologist. And he said, this is not all it's cracked up to be, that I was told that it would be like in clinical practice. I want to think about something else. It's a more impatient generation than my peers, certainly. And they're not going to put up with a system that doesn't work well, where they're not satisfied. So they're turning to get more education so that they have some career options. But it's a very different group. The other thing we hear from them is that they enjoy working in multidisciplinary teams. They're very easily able to abandon autonomy in favor of team dynamics, and they really enjoy that. So I'm very optimistic about the newer generation of physicians, and I think, frankly, the older generation of physicians can learn a lot from them about lifestyle choices and balance in their life and the primary focus.
You've been a supporter, a believer of the dyadic model, and we've talked about that in class. You've certainly been liberal in the journal with that theme, and I think that probably follows along the theme of being collaborative. Do you think it can really work? Can you have a real dyadic model, or is one person really in charge at the end of the day? How does it work, and how does it work best?
Well, I do support the dyadic model, but I guess I would qualify that by saying that I support it at a certain point. Somewhere, along the path to maybe a very senior leadership position. And I think it works well for physicians that are early in their management careers. And frankly, I think it works well for non-physician managers as well, to be able to really intimately know how to work with physicians. And I've had experience myself with the dyadic model. As I was thinking about that, I thought, oh yeah, I did that and I loved it. I was at a large national health system with 70 hospitals in 20-some states. I was asked to co-lead the National Patient Safety and Quality Program. And I was paired with a non-physician who had only a couple of years' experience in the healthcare industry. Now, I could have looked at that and said, whoa, this doesn't feel good at all. But I learned so much from working with him. He came out of the manufacturing industry, had a master's in engineering. And what I learned from him about cutting through the crap and the waste, primarily using Toyota's lean principles, but other things like how to run a meeting, how to make sure that decisions are made quickly, that you don't always need gigantic committees to make a decision that impacts patient care. And I know I enjoyed working with Jeff. We're still close friends. He's also on our faculty at ACPE, and I think he feels the same about working with me. It's a great experience. Now, if you get into the CEO suite, I don't think you can have a dyadic relationship. But I think for people that are moving along in their careers, that is absolutely something that's valuable for both people. I think it works well if both people understand that they're there to be a resource to the other and to the entire organization. Chuck Dwyer from the Wharton School teaches influence at ACPE, and one of the things that he always talks about is if you want to go to extremes in an organization, there's kind of two different types of people that you can look at. One are what he calls competitive seekers, where each person is in it for themselves. They want the advancement, often at the expense of someone else, and they'll do anything to get that advancement. They crave attention from the organization for their leadership and management skills. And the other type of person is just the opposite. It's the type of person that says, I'm here as a resource for my dyadic partner, for everyone in the organization, to help everyone improve. And then learning how to get what you want, very selfishly, get what you want in your career by making sure that everyone you work with gets what they want and what they need. And then if you have everyone working in an organization that are those resources, think of themselves as organizational resources, you've got a very high-performing organization. But if you have an organization full of competitive seekers, my goodness, that is not a fun place to work.
Does the physician manager, physician executive, physician leader need to practice medicine?
My personal belief is it's an individual choice, and the answer is no. I don't think so. Here's why. It's really much more about how you make decisions and how that comes across to your peers, your physician peers. For example, if you claim that you're a practicing physician, but all of your decisions don't seem to have much relationship to what the practicing physician finds important, which is trust, respect, telling the truth, and focus on patient care, then it doesn't make any difference how many hours they put in the clinic. It's not going to work. The higher you go in management, typically the harder it is to see patients on a regular basis. Occasionally, in some instances, there may be some conflicts of interest for a physician in, say, an insurance setting or in an integrated system that has its own insurance plan to see patients because there could be a perception of withholding care because the insurance part of the integrated system would do better. Some physicians like to do it because it feels like you've got something to fall back on if your management career flops. But the other thing is, you know, I went back to the bedside about 1.5 years ago before I started at ACPE because I believe that David Halberstam's quote about authority is correct. And he said, if you're in a position of authority, if you don't, you're a long ways from the front lines. And if you don't know what's happening at the front lines, you don't know the truth. And I wanted to get back to see what it was like after not practicing for about 15 years. It was terrifying because I thought, my gosh, I used to be really knowledgeable about this, but the patients now, you know, that I would have seen in the intensive care unit are now in specialty outpatient hospitals. And it was intimidating. So I think and I got a mentor right away, a physician that I had hired years earlier who now ran his own hospitalist program. And I had a great experience, but only because he was willing to help me out with this. So I realized I might not be safe in doing just dabbling in clinical care. So fundamentally, it's at the end of the day, it's about the quality of your decisions and do they make sense to your clinical peers.
I'm assuming you told those patients, I haven't done this in a while, so just sort of bear with me.
I told that to some patients, you know, but I said,
I want to give this a whirl again.
That's right. But I always prefaced it by saying, Dr. McConnell is backing me up. And they said, oh, good, because he's great.
You know, you see you travel extensively, you're called into a lot of organizations. Do you see any organizations that are becoming especially innovative with the whole physician management thing?
I would say yes, and I think there are some common names that you see coming out of Washington as healthcare reform is talked about, and these names will be very familiar, I think, to many of your students. Mayo is clearly one of the organizations at the top of the list. I would say probably Gunderson in La Crosse, Johns Hopkins, the Kaiser system. They all tend to be Geisinger, Centera Healthcare in Virginia. Many of those systems have invested heavily in developing physician leaders as clinical leaders. Some of them are run by physicians, but not all of them. And I think the innovation comes more in operations. I mean, it's not the disruptive kind of innovation that maybe changes the nature of the industry overnight, but they've certainly figured out how to do things very well so that they have good quality outcomes, but also relatively low cost compared to other places in the country. I think that some of the, growing up across the border down in Iowa, right across the Minnesota border near the Mississippi and in Wisconsin, I grew up thinking that as a physician that I would be working in a team environment, much like the Mayo Clinic. And I was quite surprised when I got out west, where I've spent my career, to find that that's not the way many physicians think out there. But I think as healthcare reform is on the horizon and people are talking about maybe payment reform, focus on quality, I think the concepts of these systems that I've mentioned are going to be really important for other physicians and other healthcare organizations to think about.
Yeah, as we see the models of healthcare change, whether they evolve to integrated models or the next model, whatever the next generation is, and we are adding physicians to the mix, physicians in governance, senior leadership, middle management, clinical service management, there's an obvious question begged, which is the so what? Are we getting better performance? You seen anything in the literature or anything anecdotally that would suggest that with the addition of physicians in the mix, things are getting better?
Yes. If you look at McKinsey Quarterly, February 2009, there was an article called When Clinicians Lead. It wasn't specifically focused on physicians, but a lot of the examples that they used were physician examples. It was written by a young surgeon in London named James Mountford. When I saw the article, I called James and asked him about, he had it referenced, what he was looking at. He mentioned specifically the VA system that was in a shambles several years ago until Ken Kaiser came in and started changing the structure of the system to focus on clinical excellence. Ken eventually went on to head, I think it was the National Quality Forum. He also mentioned the Kaiser Permanente group in Denver, Colorado that was not performing well. Had a physician come in that revamped what they were focused on, did very well. He mentioned a couple of systems in Great Britain where, not necessarily run by physicians, but having physicians as clinical champions all along the different departments. And he said on many measures of performance, it looked like they were doing at least 50% better than systems that didn't have that kind of clinical leadership. The other thing I remember specifically from several years ago when I think it was, there was a firm that listed the top 100 hospitals. And what they noticed is that the hospitals in that top 100 tended to have a lot of clinician involvement in management and leadership. And they said that stood out from the next group of 100 hospitals and lower. So I think there is starting to be evidence emerging that it does make a difference if you engage your physician leaders all along the way, from the bedside. And as I mentioned earlier, you can focus on improving one clinical process, or you could focus on helping a system get more efficient.
If you think about the development of physicians as leaders, what are some of the hard skills, soft skills they need that perhaps they didn't get in medical school? So hard skills, soft skills, what do they need?
It's a good question, and I kind of think it's paradoxical, because what I think of as the hard stuff may be what other people think of as the soft stuff. But I would say that a basic understanding of finance, the difference between a balance sheet and an income statement, understanding working with people.
That's a good idea. We have to do that, I think. We'll figure that out. Sorry, excuse me.
Right. But I think understanding the basics of finance, knowing what key financial ratios to look at, and even more importantly, what they mean about the organization. Many physicians that go through our courses, you know, they act when they're on the hospital board looking at those financial statements that come out at every quarterly board meeting as if they know what they're talking about.
They nod knowingly?
And they don't. And they realize that once they start taking the real McCoy in terms of finance. So I think that's really important, the basics of quality and safety and high reliability. These are all knowledge content that I think is really essential for physicians in leadership roles. Some of the hard things for physicians to do are to change behaviors, because, as I mentioned, we were not trained in our clinical training to think as part of a team, and we have to be always very careful what our tendencies are, our personalities that's gotten us through all this training, gotten us into medical school, gotten us through training, that if you're not careful with those traits, they can turn into liabilities in a health system. For example, Lois Frankel, who is a PhD, has written several books, and one of them she's talked about is physicians. She says that physicians are intelligent, they're independent, they have good analytical capabilities, good critical thinking skills, and they tend to have a sense of urgency compared to other types of people. You could say probably something similar about engineers. And when we think about those personality traits, if you use those appropriately, you can be a tremendous asset to a team, so that those 5 traits can come across as confidence, the doctor knows what she's doing, can come across as being able to analyze complex problems, find solutions, and move to the solutions quickly. If you're not careful with those 5 characteristics, they can turn into just the opposite. They can turn into, intelligence can be interpreted as elitist, you know, she's not one of us. Impatience, sense of urgency, you know, they're impatient. They can't wait for the rest of the team to make a decision. The analytical capabilities and critical thinking can come across as critical of the team. And those are very difficult behaviors to change. The reason I mention that is because it has an impact on safety and reliability. Because if you look at the characteristics of highly reliable organizations, it includes, it becomes dangerous if you have people that are not part of the team. They're acting as if they're elitist, they're separate, and they're critical of other people on the team. It creates an environment where care is not reliable. Pilots will tell you the same thing. Jeff Skiles was the co-pilot on the U.S. air flight that landed in the Hudson. Talked to Jeff a couple days ago. He's going to come and talk at our annual meeting in April about teamwork. And he commented, he said, you know, it was the first time I'd ever worked with Sully at the end of a 4-day run. I'd never worked with him before. And when the jet lost power, he said, you know, we went into the team mode. And he said, what I've found is that if you have one person in the cabin crew, on the ground crew, in the cockpit that doesn't get it and isn't acting like a team member, it's a dangerous situation. And as my son, who's a commercial pilot, always reminds me, he said, I'm a little different than you, Dad. I go down with my passengers. You don't go down with your patients if you make a mistake. So, so I think there's a lot of lessons we can learn about working well together as a team. That means it's difficult to change those behaviors as physicians, but I believe it can be done, and I've seen it done. So,
you know, we talked a little bit about this before, and that's the younger emerging physician leader. Do you find any of them that are concerned that they might be viewed by their colleagues as sort of selling out, that you're kind of going over to the other side, and how they handle it?
It's a difficult thing to be told that you've sold out. You've crossed to the dark side, is the term that's been used for years. But I had an epiphany about that when I left my clinical practice. One of my partners said, "What a stupid idea, Barry. Why would you ever want to do that? Why would you want to leave clinical practice?" At that time, I went to work for an insurance company, Blue Cross company, and I wanted to learn about financing of health care, which I didn't know anything about. So she said, "Terrible idea, and we can't trust you anymore." I said, "Why not?" "Well, you're not one of us anymore." So I thought, gee, I didn't know that would be the reaction. I mean, I was pretty naive when I made that choice. So a week later, I'm sitting at the insurance company with my new colleagues as the only physician in the organization, and they're talking about the provider panel, not the physician panel, but the provider panel, about the different groups they're going to get, et cetera. And at one point, somebody said, "We're not sure we can trust you, Barry." And I said, "Why can't you trust me?" They said, "You're a physician. You're always going to think like a physician." And I thought, what have I done? And so finally I realized,
the dark side wouldn't have you either, would they?
Right. That's right, exactly. So I thought, well, this is probably the best of both worlds. I'm somewhere in this nether world that's right in the middle, and it's my responsibility as a physician and as a leader. At that time, I did not have an advanced management degree. I said, I've got to figure out how to get this side talking to this side and not think of themselves as two different sides. So I thought, well, that's okay. It is lonely. It's a very lonely existence when you suddenly realize that your clinical colleagues may have a different impression of you, and your new management colleagues may not totally welcome you because you are a physician. So I think that's one thing that is a little bit jarring for many physicians when they do that. The younger group of physicians, I don't think they're particularly worried about that. And see it as an interesting intellectual and professional challenge to move into those roles. And I think if you've been in these roles long enough, you know, you can develop trust with both sides. I remember very well a discussion one night at a health system where the doctors were directing all of their negative comments to me, not to the CEO, who was a non-physician. But they were directing all their negative comments to me. They were very animated, very emotional. And afterwards, I was talking to one of the cardiologists, and I said, you know, maybe this was a bad decision for me to come here, because I said I just had no idea I was going to get that kind of response. And he said, oh, no, Barry, you need to understand. we want you there because we wanted you to hear exactly what our concerns were because we think you know how to translate this to the CEO. And I said, oh, thanks. But those kinds of things happen all the time. And I think that's, frankly, one of the reasons that systems want to have physicians in these roles that are able to take that and able to translate those very real and very valid concerns into language that managers and leaders can understand.
As you noticed, we have a class here of very experienced, accomplished professionals. And I was watching them work in groups today, working on cases, and it dawned on me that we could be all part of one organization. I mean, this could be the management team for a large health system. And I was watching them work together, which was a terrific thing to see. In the spirit of collaboration, what sort of advice would you have? What is the place for the team going forward? And I know I've asked you that question in other forms, but I want you to sort of address the students, if you would, on what they should expect high-performing organizations to look like with respect to teams and teamwork.
Mm-hmm. I guess the first thing I would say is that disagreement is good, and it should be welcomed, and it should be okay. Diversity of opinion, diversity of thought, diversity of backgrounds, whether it's gender, ethnic background, et cetera. If you don't have that kind of environment, then I think that's dangerous because you're not going to get the best decisions made as an organization. I think in terms of the characteristics that you'd be looking for in the leaders of the organization, a team leader, the overall leader of the organization, I think there's some key factors, whether you're thinking about physicians or not, need to be bone honest about what's going on, need to be able to focus on the good as well as the bad, and I guess I would borrow some of Jim Collins' concepts of really good leadership to look for. He talked about, in his book, Good to Great, level 5 leadership, which he said was surprising to him and his researchers when they looked at some of the greatest companies in the world. And they were looking for the cult of the ego, the leader that was almost had a cult-like status. They didn't find that. What they found were leaders that tended to have humility. They gave credit to other people for the performance of their system. He talked about the phenomenon of the window in the mirror, where when things are going good, the good leaders look out the window and they give credit to their team members for the good performance. When things were not going well, they would look in the mirror and take accountability and responsibility for things that weren't going well. And they would even say things, I mean, very different from what the auto companies right now and the bank executives are saying about the problems in their industries. These leaders that he talked about would say, I'm responsible. I should have seen the recession coming. I should have seen, events that most people would say, you had no way of knowing that would happen. He said they tend to lead with questions rather than answers. They don't have all the answers. That's something that we have to be careful of as physicians, I think, that, from our clinical backgrounds, we think we have a lot of the answers. But we really should be asking questions, the right questions, so that other people can process that information through questions. He talked about leaders that conduct what he called autopsies without blame, which we should be pretty good at as clinicians, saying what went wrong, and let's not blame, but let's just look at what happened in this situation. I think teamwork should be fun, not boring. Meetings, you should look for meetings that start on time, end on time, are going someplace, have specific accountabilities at the end of the meeting. Physicians will appreciate meetings like that a lot more than typical health system committees that kind of meander and wander and don't really have specific next steps and don't follow up with that. So those would be some of the things that I think are really important to look for in good teamwork.
Given the fact that our students took their time to be here, I'd like to turn to some questions, if that would be okay with you. And Barry was kind enough to to take questions. We have questions from the class tonight.
It seems there's a number of physician leadership programs through the Society of Hospital Medicine and the ACP and others. Could you speak to how you distinguish among those, or if there's much that differentiates all those kind of colleges or organizations that aim to develop physician leadership?
It's a question that we've been grappling with at our board level as well. It seems like a lot of the physician leadership programs are now becoming a commodity because so many different organizations say, we want to train physician leaders. Frankly, the curriculum, even some of the instructors, are pretty much the same from one program to another. What we want to do at the college is say, how do we distinguish ourselves from the other programs that exist? I think they're all, from what I've seen, they're all very good. The advantages I think that we're trying to put in our programs are, this is actually put on by physicians, and what we want is anyone that comes to these courses, including hopefully our new membership categories, know that they're going to be sitting there as equal peers with the physicians in these courses and understanding maybe what Dan's getting at is our physician, do they really think differently? What is the it in terms of clinical leadership? It's a challenge, and it's still evolving. But the other advantage that we have at ACPE is that most of our core courses can be applied towards advanced graduate degrees if that's something that is of interest to physicians. We find a lot of physicians, for example, that they're not quite sure if they want to get deeply into management. So they want to get a couple toes in the water, see if it's something that they're really interested in, and then if they want to, they can apply that towards an advanced management degree. We're seeing that more and more as well.
So Dr. Jacobs' questions was, I inferred this, and you did as well. There seems to be a lot in the marketplace right now.
Right.
And physicians have a lot of choices for leadership training or management training. Does your organization have at its role as one of its roles to help sift through that? Can they call you and say, look, here's a course, and have you guys probably thought about whether it's a good one or not?
Yes. We do that a lot. Right now there are 3 major universities that are affiliated with ACPE where physicians can apply those courses to an advanced management degree from those particular programs. Like I think probably the admissions group does here at the University of Minnesota, we also find physicians say, well, I think I want to go to Carnegie Mellon, and we'll talk and listen to what they're saying and say, you know what, for what you're interested in, maybe you want to go to USC or University of Massachusetts at Amherst, depending on what we hear over the phone.
Or the University of Minnesota, in Minneapolis.
That's right. That's right. We're talking about that.
We are.
And Dan's on our faculty, as you know. So, and I need to share this with the rest of you. As we prepare for our Winter Institute in Naples, Florida, in a couple of weeks, as we look at the enrollment, we've seen the enrollment go way up from what we've seen over the past 3 years. The most in-demand course is Dan's course on integrated health systems. We had budgeted for 75 attendees. We right now have 105, and we've had to put a freeze on anybody else getting into that course this time because of space limitations. So, and a lot of people are upset. They say, well, I want to go to that course, and I want to go to it now. So, I mean, hopefully they'll hang on until the next course, but that's the kind of thing that what we're trying to do is focus on topical issues that are of interest to our members. I've realized probably 4 or 5 months into my new job at ACPE that every time a physician enrolls in an advanced management program, whether it's any of the 3 that are affiliated with the college or Minnesota or any of the others that have sprung up across the country, I think unless the college changes in terms of the course offerings and the content, we'll lose them as members. Because once you have an advanced management degree, you can't go back to the 101 courses in management, finance, and things like that. So part of our challenge is to come up with what is the latest that healthcare leaders want to know about. And hopefully we're moving in that direction.
Other questions?
I wonder if you foresee a time when management and leadership courses really become mandatory as a part of training physicians and not just something that is an option or recommended.
Let me restate the question because we don't have a mic out there, and it's
Okay.
a good one. Thank you. The issue of in medical training, whether it's medical school, residency, fellowships, whether management and/or leadership training becomes mandatory.
Yeah, it's a very timely question. Right now, we have a task force that's been set up on medical education that reports directly to our board. It's one of 7 task forces. The reason that we wanted to do that is because we're hearing from many young physicians and some of the enlightened medical training programs that their graduates are coming back 3 years later. They're saying, you did not prepare me well for what I'm facing in the marketplace. And as they've had those discussions, realized that had no training at all about leadership, about teamwork, about safety and high reliability, about how human beings make mistakes, and we all make mistakes, even as physicians, and how organizations work, how to maneuver within organizations. So I can tell you that the National Patient Safety Foundation is probably going to be releasing a white paper fairly soon about additional training in the medical environment that would address some of those topics. One of the co-chairs of our task force is a physician hospitalist that is about 3 years out of his training, and he's helping us with this because he has actually introduced these concepts into medical training. And I've been part of his courses and taught there, and it's amazing to see young physicians gravitate to these concepts so quickly, and they understand the importance of it because, you know, I think they can see how dysfunctional the healthcare system is that they're forced to work in the training setting, and then once they get out and go into practice, they're seeing it even more.
Other questions? If not, I want you to know that this is a very important part of our educational process, and having folks like you come adds greatly to it, and we thank you for that. And thanks for taking your time with us.
I'm glad to be here, Dan.
It's a pleasure.
Thank you very much.
You guys want to do the cutaways?